And these are really very important aspects, not just in clinical practice, but critically important in clinical trials. So what are the tools that we use to assess these aspects? Well, there are many tools. There are certainly at least 12 different disease activity tools for use in lupus. But the two that are emerging, certainly in clinical trials now, are the BioNICE British Isles Lupus Assessment Group and the SLEDAI, SLE Disease Activity Index. And these are now becoming the sort of industry standard in clinical trials in lupus. The problem here is that they were never designed for use in clinical trials, although BioNICE probably lends itself better than SLEDAI. So each of them has got its faults, but I don't have time to go into those points. Damage is very important. So damage describes irreversible scars. So avascular necrosis, end-stage renal failure, cataracts, those are sort of damage items. There is only one scoring system for that, and that's the American College of Rheumatology Systemic Lupus International Collaboration Clinic Damage Index. It's well validated, widely used, and captures damage very well. And quality of life is something we neglect all the time. There are generic markers, the SF36 and the HAC and many, many others, but there are now increasingly lupus-specific quality of life assessments. And these ones, they've put this one together, the lupus qual, which is now being used in clinical trials. The main aims of treatment in lupus are clearly to reduce inflammation, prevent thrombosis, as per my earlier talk, and we recognise that it's told you that damage predicts premature mortality, and so we need to avoid, our whole strategy should be to avoid long-term damage. What agents we use, the choice depends on the extent of the organ involvement, the risk of thrombosis, and obviously pregnancy and fertility issues, given that our patients are usually young women who want to start families. So the therapy of lupus, the only drugs that have ever been approved are aspirin, antimalarials, and that's it, basically, and steroids. And so we use all these drugs that we're very familiar with, but none of them have ever been formally approved by the FDA or European agencies. Antimalarial therapy is the bedrock of lupus therapy. I think all patients with lupus should be offered the opportunity to be treated with antimalarials. These are the usual drugs, hydroxychloroquine, metoprolol, or quinaquine. We don't use chloroquine anymore, but I recognise this is very widely used in other countries. And certainly combination antimalarials are very useful. I might touch on that in a minute. These are safe drugs. We've had patients been on these drugs 15, 20 years without any long-term adverse effects. They are truly disease-modifying, as demonstrated by the Canadian Hydroxychloroquine study group published in the New England Journal of Medicine in 1991, which clearly shows that these agents reduce relapse rate. They improve lipid profiles, they improve glucose profiles, so they are useful in counteracting some of the side effects of steroids, and they have, as I said earlier, clear antithrombotic effects. And many, many studies now, both prospective and cohort studies, have shown that antimalarial use reduces the risk of damage and reduces the risk of premature mortality. So there is a compelling case to offer antimalarial therapy to all lupus patients. They're pretty safe drugs, as I've already said. Chloroquine, you're well aware about its retinal toxicity. Hydroxychloroquine, I've only ever seen one patient in my whole career who really had convincing evidence of hydroxychloroquine retinopathy. So it is vanishingly rare. Common side effects, rashes, diarrhea, you're familiar with. These are often fairly transient. If you have a rash, however, you should not use hydroxychloroquine again. Mepoprine, otherwise known as quinaquine, is very rarely used, but mainly because there are manufacturing problems with it. It's just so rare that anybody uses it at all that boots the chemist who make it run into production problems every so often. They threaten to stop making it, so it is difficult. We get so much supply from it. But this is an incredibly useful drug. Didn't put it in. When hydroxychloroquine alone fails, I often use a combination of mepoprine, half a tablet Monday, Wednesday, and Friday, together with hydroxychloroquine. And that combination, I think, was suggested by Richard Sontheimer in the States, and Graham Hughes really publicised it. And that combination really works extremely well when hydroxychloroquine alone fails. Remember that smokers tend not to get the full benefit of antimalarial therapy. So antimalarial therapy is useful for this type of patient with joint pains, rashes, photosensitivity, mouth ulcers, and alopecia. Those sort of